Hello, class. This is Mrs. Narod, and I am going to present to you our lecture for Nursing 254 Adult Health Theory on Myasthenia Gravis, Guillain-Barre syndrome, and then trigeminal neuralgia. So, objectives for today's lecture are to differentiate between the pathophysiology, etiology, clinical manifestations, and direct and indirect causes of myasthenia gravis, which you might hear me refer to it as MG during this lecture, and then Guillain-Barre syndrome or GBS, and trigeminal neuralgia. Identify risk factors and prevention methods associated with those. Illustrate the nursing process in providing culturally competent care across the lifespan for those individuals. We'll look at formulating priority nursing diagnoses. We'll summarize therapies used by interdisciplinary teams in collaborative care. We'll plan evidence-based care for all individuals with those diagnoses, and then we'll look at expected outcomes for individuals with those diagnoses as well. So a little background on what myasthenia gravis is. So it's technically a motor disorder. It's characterized by fluctuating localized skeletal muscle weakness and fatigue. So when you think about myasthenia gravis, think about muscle involvement. So it's an acquired autoimmune disease in which antibodies directed towards ACH receptors, which are acetylcholine, and these antibodies attack these these acetylcholine receptors on the muscle membrane. So essentially, it's the body's immune system that is attacking healthy skeletal muscle cells. So in this slide here is figure 38.1. And if you look at that closely, you can see the acetylcholine or ACH. So if you see ACH anywhere in the lecture, that's acetylcholine. So it has an important job when it comes to activating skeletal muscles and nerve cells and making muscles move. So you'll see that it's attaching to the nicotinic receptor sites and the muscle fibers. It's important with getting that muscle to move. Um, so, with myasthenia gravis, the disease, it'll vary in severity from mild to severe, and each person will be totally different. And we'll go into this a little further. And then also, it affects each person differently in specific areas of the body. So they might have ocular symptoms, such as ptosis, where they have the eye drooping, or drooping eyelids. It might be one eye, it might be both, it might be left eyelid, or it might be right eyelid. They can also have diplopia, which is double vision, and some may have it, some may not. And then in severe cases, they may even have generalized weakness and even respiratory involvement. Some facts on myasthenia gravis. So in the United States, it's about 14 to 20 people per 100,000 who are diagnosed with it. And although it was previously more common in women, it's now more common in men. The average age onset in women is anywhere from around 20 to 40 years old, so it's in younger women. But again, these are generalizations, and it can happen at any age. Whereas men, it's usually later in age, and the onset's anywhere from 60 to 80 years old. So typically it does affect younger women, and it's a disorder that affects older men. Although most patients you'll see, at least in the hospital setting with severe disease, are going to be your elderly. And then they really don't know yet what the risk factors are associated with developing the disease. There's a lot of science behind myasthenia gravis, and there's still a lot of unknowns. Okay, so pathophysiology behind it. We talked a little bit about ACH, a little further into that. So We talked about the normal electrical signals and impulses that travel down. You have that motor nerve. Those nerve endings release a neurotransmitter called acetylcholine, or ACH, and that binds to those sites that are called ACH receptors on that muscle. And that binding to that receptor activates the muscle and causes muscle contraction. So in myasthenia gravis, antibodies, which are produced by their own body, so these immune proteins are produced by the body, and they block, alter, or destroy the receptors for acetylcholine at the neuromuscular junction. So it completely prevents the muscle from contracting. So remember, with these patients, they have definitely enough adequate amounts of acetylcholine released. It's just that these receptor sites are not available. So they're either blocked, altered, damaged, destroyed. They just are not available. So this is the most often caused. With these receptor sites not being available or damaged is most often caused by the antibodies that are formed from acetylcholine receptors. Those antibodies that are attacking the acetylcholine receptors itself. There's also other antibodies that can do this. So we'll talk a lot about the acetylcholine receptors being affected and the antibodies that directly affect the acetylcholine receptors, because it's the most common cause with myasthenia gravis. But I think it's important to know that there are other antibodies that the body can produce and other proteins that can damage those receptors and impair transmission of the neuromuscular junction. So you might also hear it's called muscle-specific kinase, which is up there in the slide, or it's abbreviated MuSK, M-U-S-K. And I've heard of this before, just in background with what I've learned as a nurse. It's not a common test or something that they'll be looking for. It's very specific only to myasthenia gravis. But just so you know, those are the two most common antibodies that they'll be looking for with myasthenia gravis. So about 80% of patients, you'll find that it's that anti-AChR antibody. So the one that was attacking those acetylcholine receptors. So the antibody that goes to the acetylcholine receptor, which they say is the anti-AChR antibody, is about 80% of the cases or patients with myasthenia gravis. And then about 10% are that other protein antibody, the MuSK type. And then I guess others, about 10%, have no identified circulating antibodies, which is referred to as SNMG or seronegative, which means they can't find a protein antibody. The other thing with myasthenia gravis is the thymus gland seems to be involved quite frequently with these patients. So if you remember right, the thymus gland grows until we reach puberty, which then it reduces in size and is replaced by fat. So it kind of doesn't serve as a function anymore after puberty. As we're younger and throughout childhood, the thymus gland is an organ that helps with the immune system. It produces T cells or T lymphocytes, and it helps to defend against infections and viruses, essentially until we're old enough to either be exposed to enough of those things or able to produce, where our body is developed enough and we can produce those things on our own. So typically with myasthenia gravis patients, they'll have a large thymus gland. And, as I said, with puberty, it usually shrinks and decreases in size and becomes more fat-like gland. So with myasthenia gravis patients, they'll have a large thymus gland, and then they'll also find clusters of immune cells in them. And it's because of these antibodies that, the body releases this immune response, and the antibodies that are being created in response to what's going on with the body. So 70% of patients have what's also called thymic hyperplasia. So that's what's called an enlarged thymus. And then another 10% will develop what's called a thymoma, which is a tumor of the thymus gland. So although they're really not quite sure why there's this association between the thymus gland and myasthenia gravis. They have their, scientific reasons as to why they think it's associated. But they think that, it may be because there's these flawed instructions that are developing between our immune system and that thymus gland, and then also in resulting in that development of the AChR antibodies, and how that goes and then destroys the receptor sites. So that's what they're thinking. Again, they're not 100% sure what the cause is with the thymus gland. So the tumor of the thymus gland, or the thymoma, it typically is benign, so typically non-cancerous and enclosed, but just know that in rare cases it can become cancerous. They usually will remove it, because once they remove it, these patients tend to get better. They will have significant levels of antibodies because of the thymoma. Think about what's happening to the body with that tumor there. So they'll have much more of a severe disease course if they leave that in there. And what it's called is a thymectomy, and that's a surgical procedure that myasthenia gravis patients will have to remove that thymoma. We'll talk a little bit more about that too. So, clinical manifestations. Myasthenia gravis is categorized into 3 different presentations. So you have ocular, bulbar, or generalized presentations, and patients will often seek care for, usually it's more generalized muscular weakness and fatigue. So I wanted to go into more of the 3 types here, and then I also included a table up there of the cranial nerves for you. So let's go into the ocular presentations. So 2/3, which is a pretty significant amount of patients, they will have ocular symptoms. Namely, it's what we talked about earlier with the ptosis, where they have the drooping eyelid and will have double vision or diplopia. Many patients experience these symptoms within 2 years of their onset of the disease, and then the eye drooping can either be one eye, or it can be both eyes. So it can be unilateral or bilateral. And then the double vision is just usually a result of weakness. It's all muscle weakness, and ocular symptoms can worsen with activities that require sustained use of the eye muscles. So the thing with myasthenia gravis is that usually the symptoms will worsen as as fatigue sets in. So the more muscles that they use, the more tired they get. Bulbar symptoms are usually the first to appear, and they're in about 16% of patients, so not as many. They refer to more clinical manifestations involving the multiple cranial nerves, and that's why that table is up there for you to try and remember those cranial nerves from way back. So cranial nerves 9, 10, 11, and 12 specific to the bulbar area. So these cranial nerves emerge from the medulla of the brainstem. And if you want to go ahead and brush up on your cranial nerves. Table 35.6 on page 766 is where you go to look at all of your cranial nerves. And so since the medulla is shaped like a bulb, a tulip bulb, this is how it's linked to the term bulbar. So bulbar clinical manifestations include difficulty with phonation, so pronouncing things, chewing, and swallowing. And then if you look at all the cranial nerves that are involved with the bulbar presentation, so your cranial nerve 9 is glossopharyngeal, and that deals with functions, taste, touch, pressure, pain, temperature, your regulation of blood pressure and respirations, and then your swallow and gag reflex. And then cranial nerve 10 is your vagus, deals with taste, hunger, fullness, GI discomfort, GI secretion, motility, bronchoconstriction. And then 11 and 12, so that 11 is accessory, 12 is hypoglossal. With 11, you worry about swallow, head, neck, shoulder movements, and then 12 is more with food manipulation and swallowing and speech. So you can see how these are pretty, important cranial nerves that are affected by myasthenia gravis. And I'm sure you're already thinking of the things as a nurse, what we might have to worry about with these patients. And then generalized presentation. So it's in roughly about 16 to 20% of these patients, they develop trunk weakness and limb weakness, which are the initial clinical manifestations for them. And typically these patients experience greater weakness in proximal muscles than distal muscles. So really, myasthenia gravis can affect any muscle in the body. But the muscles of the neck, deltoids, triceps, wrists, fingers, and ankles are commonly affected. The hallmark of myasthenia gravis is muscle weakness that worsens after periods of activity and improves after periods of rest. So they're doing a bunch during the day and they keep getting more and more weak throughout the day. And then as soon as they rest, they have their strength back. That's a classic sign. Weakness varies across the day, but generally it worsens later in the day and in the evening. And then clinical manifestations will worsen with sustained muscle use. So same thing when you involve the eyes or any sort of eye movement, if you're doing a lot of eye stress or a lot of computer work for them, that is going to tire them after, throughout the day of working at the computer. So again, it'll vary for each individual. Patients may also complain of difficulty with completing activities of daily living, such as bathing and dressing. And again, depending on which presentation they are, they may have difficulties eating, swallowing, moving in general. So it's very specific to the patient. So this illustration is of some of the clinical manifestations of myasthenia gravis and the presentation. So we talked about ocular with the diplopia, ptosis, ophthalmoplasia, bulbars, fatigable chewing, and that is something that as well, the more that they chew, it gets more tiring and tiring and tiring because they're using their muscles, so it increasingly gets more tiring. Dysarthria, with difficulty chewing, and then dysphagia with swallowing. They always have a lot of difficulties with swallowing. Those muscles just are so weak and don't want to work. And then with respiratory, in more of the severe cases, we really have to watch out for just muscle weakness in general with not being able to breathe. There's breathlessness, respiratory failure. They have very weak breathing. They're probably more inclined to develop pneumonia and infections and atelectasis. And then the limbs and neck. So that's more your generalized. And then, just with the muscle weakness with shoulders, they'll have the dropped head. Proximal is distal in arms and legs. So proximal muscles are more affected than the distal. And then arms too seem to be more affected than the legs when it comes to muscle weakness with these types of patients. Okay, so we talked about the thymus gland and how that is involved, and they do have a thymoma, that tumor of the thymus gland, it requires surgical removal in order for them to have improvement of their symptoms. So a thymectomy is what is done, and it's a surgical approach that is interesting. So we'll go into how they surgically remove the thymus gland. And really what it does is as soon as it's removed, it rebalances the immune system. So it's usually performed within the first 3 years that they're diagnosed, especially if they're under the age of 65. The younger they are, they'll do this. Definitely more, the sooner the better. You do not want them to have, long-term symptoms. You want to try to treat it as early as you can. And then this surgery, again, is almost always performed for patients with the thymoma. So there's a couple different surgical approaches. It includes transsternal, transcervical, and another one is video-assisted thoracoscopic surgery, or a VATS surgery. They also have a video-assisted thoracoscopic extended thymectomy, or a VATET, VATET. But we'll talk about the most common one, which is the transsternal extended thymectomy. So that's the standard approach. It involves making a midline incision through the sternum to expose the thymus and remove it. So these are pretty extensive thoracotomy kind of, you're really going into the thoracic region and taking this thymus gland out. Usually with chest tubes afterwards. They're pretty intense surgeries, and they require quite a bit of downtime afterwards. Reminds me similar to like the cabbage procedures. Obviously not with the procedure itself, but maybe more with the recovery and having thoracic surgery in general. So close monitoring afterwards is needed. They're typically in the ICU after surgery, mainly monitoring for symptoms and respiratory status, because you would expect there to be this sudden improvement in their symptoms and that their weakness would improve. They wouldn't have any respiratory weakness and they would just be much better. But it just depends. It really depends. Sometimes they can have an increase in myasthenia symptoms afterwards, which it can be related due to anesthesia, analgesia, sedation. They may have had an omission of some medications intraoperatively or before surgery. So you just have to be really careful and watch these patients postoperatively for any worsening symptoms and, of course, respiratory arrest. So that's your biggest concern with these patients, is the fact that they could have such muscle weakness that they can no longer breathe on their own. Let's see. One other thing they can do is pulmonary function testing. So they can do what's called forced vital capacity testing, or negative inspiratory force testing. And that typically is done by the respiratory therapist, especially if they're going to be still intubated post-operatively, or if they're intubated because they're so respiratory muscles are so weak. But if they're not intubated, then I would definitely try to involve respiratory therapy on that, because they're more trained on pulmonary function testing than typically nurses are. So really with the pulmonary function testing and that forced vital capacity, it's just, we're really trying to assess and evaluate how well their respiratory system is functioning. Are they able to take deep breaths? Are they able to exhale really well? We really want to be able to assess how strong or weak their pulmonary muscles are. So we'll definitely do lots of monitoring of respiratory status, rate, depth. We'll look at their work of breathing, breath sounds, oxygenation, ventilation, tolerance. We'll look at their chest tube if they have one. They might have quite a bit of output afterwards. If they're on the vent, we're going to do some spontaneous breathing trials, see how they do on their own. And we'll have respiratory therapy involved to do some pulmonary tests, whatnot at the bedside. Let's see. So for the vital capacity testing, what that is the patient inhales as deeply as possible and then they exhale. So they taking as much time as possible. So they just keep letting out air until they can't anymore and they have to take a breath. So it's kind of a forced exhale from the lungs. And that also should be ordered just so we can assess their lung status and respiratory status. So I think that's it about the thymectomy and surgical management. So other complications that occur with myasthenia gravis can be a myasthenic crisis or cholinergic crisis. So a myasthenic crisis is this exacerbation of myasthenia gravis weakness. So it's a patient who has myasthenia gravis that all of a sudden just has this severe weakness that develops and it provokes an acute episode of respiratory failure. So this is what you're watching out for. So you're watching out for somebody who develops a myasthenic crisis. They're the ones that no longer can breathe on their own because their pulmonary muscles no longer can function and they cannot breathe on their own. They need to be intubated. Usually it's caused by a respiratory infection, could be viral or bacterial. It's hard to say. Usually there is a cause like that. It's an acute episode, so it's not going to be long term. Weakness usually involves, again, the respiratory or bulbar muscles, and it will definitely affect the patient's ability to protect the airway. So other things that we might see with a myasthenic crisis are tachycardia. They'll have very flaccid muscles. So everything is in exacerbation. So you have your myasthenia gravis patient, what they normally are like, and then this is the extreme. So everything is exacerbated for them. So they have flaccid muscles. They'll have pale and cool skin. It's an emergency. So if they start to develop this is good patient teaching too for them at home. So, if you develop this at home, then that means you need to come to the emergency room right away. If all of a sudden you get suddenly super weak, flaccid, having difficulty breathing, then you need to come in. So it's important that they recognize these symptoms are an emergency and that treatment's important. And they'll usually go right into the intensive care unit. Usually the crisis lasts about 2 weeks. It'll vary by patient. And then there's lots of other drugs that we can use to treat for this myasthenic crisis. Usually we do intravenous immunoglobulin or plasmapheresis, and we'll go into what those drugs are. And that's used to manage the patient throughout the crisis. The other complication is cholinergic crisis. So that is another one that can also kind of develop into respiratory failure. And this is due to excessive anticholinesterase medication. So usually it's more medication-related complication, and it's potentially secondary to the patient taking too much of their prescribed myasthenia gravis medication. So features of a cholinergic crisis include muscle fasciculations, which are muscle twitching, like really fine muscle twitching, bradycardia, sweating, there'll be pallor, excessive secretions, and small pupils. It can be a little difficult to distinguish between which one, between cholinergic or myasthenic, but because they kind of both have similar features. Although one is tachycardia, one is bradycardia. So I did created a table for you a couple slides ahead that breaks down both of them for you to help you study the differences. So let's see. There is a test that they could do to distinguish between the two different types. So they can do what's called a tensilon or edrophonium test. It's used to distinguish between the two. It has a rapid onset and short-acting test that can be done, and it really is just for the reason to identify which type of crisis it is and select the appropriate treatment. So when tensilon is administered, and its medication, if the patient demonstrates muscle strength improvement, it's determined to be myasthenic crisis. And if tensilon is administered and the patient demonstrates fasciculations and muscle weakness, including the respiratory muscles, it's a cholinergic crisis. So then anticholinesterase medications are temporarily discontinued in a cholinergic crisis. So just got to discontinue those medications until the symptoms of the cholinergic crisis are relieved and symptoms improve. And then slowly they can add those medications back in and hopefully it won't start again. Okay, so medical management. So some diagnostics that we're going to do for these patients. So typically it's based on the clinical assessment as well as analysis of some of the things that we'll do with diagnostic tests. There's serological tests that we'll do. There's some blood work. We talked about some of the antibodies that they'll look for, that AChR binding antibodies that they have found, and that MuSK antibody. So those they can look for serological testing. Remember that AChR binding antibodies found in roughly 80% of the patients. And it's pretty specific to patients who have myasthenia gravis. Let's see. Patients with that MuSK antibody are found in about 1/3 of patients. And another thing with that MuSK one is generally females with prominent bulbar clinical manifestations, shoulder, girdle weakness, and respiratory weakness. There's also repetitive nerve stimulation and electromyography. So they can do repetitive nerve stimulation. It's a tool to evaluate neuromuscular transmission, and it measures muscle action potential after this repeated nerve stimulation. So with nerve stimulation, it stores ACH at the neuromuscular junction, and if it's depleted, if there's a failure to generate an action potential, then in myasthenia gravis, you're not going to get that muscle response with that repetitive stimulation. So then you would find out if they are diagnosed with it that way. The other thing that they can do is single fiber electromyography. So this is the most sensitive diagnostic tool for detecting an abnormality in neuromuscular transmission. This test requires needles to be placed in the muscle to measure electrical activity. And it records normal muscles, and it's an evoked response from two muscle fibers firing, and then with minimal fluctuation in the interval between the two. So this fluctuation is called a jitter, and it's due to the variable time required for neuromuscular transmission from discharge to discharge. So if they have myasthenia gravis, there's an increased jitter. So that jittering result is increased. And then we talked a little bit about the tensilon or edrophonium test. And that is another diagnostic test that can confirm it. So up to 10 milligrams of edrophonium, which is a short-acting anticholinesterase medication, is administered via IV push, and it temporarily improves neuromuscular transmission by inhibiting the ACHE, anticholinesterase, which is the enzyme that degrades anticholinesterase after binding to the ACH receptor site. So before the medication is administered, the provider focuses on a weak group of muscles, such as the ocular muscles, and then they give an initial dose of 2 milligrams, and they have the patient look at a visual object, and they have them do sustained visual focus on that object, and then the provider assesses for improvement of the ptosis, which is the most visually easy to see if it improves. And then if no effect is observed, then they give additional doses of 3 and 5 milligrams at 1 minute intervals. And then if there's noticeable improvement of muscle weakness at 2 to 5 minutes, followed by a return to baseline over the next 5 minutes, then that's a positive test. Let's see. So some side effects of the edrophonium includes bronchospasm, bradycardia, diarrhea, increased stimulation of the muscarinic receptors can lead to that bradycardia, and then bronchospasm in the lungs. Let's see. Atropine is another one. It's actually a muscarinic blocker, and thus the side effects of edrophonium and other ACHE inhibitors can be reversed with this medication. So because it works only in the ANS, autonomic nervous system, will not interfere with the activity at the neuromuscular junction. So really, atropine should just be available to reverse any severe bradycardia that can occur from the edrophonium Tessalon test. And of course, that's only performed in the hospital. And then chest CT could be done to evaluate for a thymoma. It'll evaluate the thymus gland. And then just because the chest CT can give us a more, closer image of the thymus gland than a chest x-ray, and can let us know the size of the thymus gland and if it's enlarged. So here is that table I made of all of the different features between myasthenia crisis and cholinergic crisis. So mainly you can see heart rate is tachycardia for the myasthenia crisis, and then cholinergic is bradycardia. And then you have the fasciculations with the cholinergic, and then the skin is a little different. So just something to help you study the differences between the two. So medications, there's several that we can give these myasthenia gravis patients. So the first one there is pyridostigmine or imestinon. That's an anticholinesterase. It's a medication that is a reversible inhibitor of ACH. It improves neuromuscular transmission. It increases the ACH stimulation of the ACH receptors that are available. So it's a great medication. It's usually the first initial treatment of choice for myasthenia gravis. So this is one that they can take in the morning, every 4 hours while they're awake, and it'll help them to stay functional throughout the day and have good muscle strength and be able to live their life. It's usually a sustained release formula, but I guess depending on what they're starting at and with their standard dose, they may have to give them a dose every 4 hours until they titrate it to what they need. But they do have a sustained release formula available. And then some possible side effects are stomach cramps, diarrhea, increased secretions, nausea, bradycardia, and muscle twitches. There's also neostigmine, and that or prostigmine. It is a shorter acting ACH inhibitor. This medication is administered IV when the oral route's not available. So usually it's more inpatient facility given. It's more manageable, controllable in the hospital setting because it's more shorter acting. So let's see, monitor the IV site frequently to make sure we've got good patency. That's a very short half-life for this medication. Let's see. That's about all I have listed for this. Just monitor for bradycardia, cardiac dysrhythmias. Usually it'll be specific to the facility that you work at. So, and it's usually ICU settings that you'll give neostigmine. Immunotherapy. So there's several immunosuppressant medications that we can give to treat myasthenia gravis patients. So they're usually given when ACH inhibitors are not adequate in moderately severe to severe cases of myasthenia gravis. And actually your steroids and prednisone are the principal medications from this category that they use. So what they do is they decrease the immune attack on the proteins and receptors in myasthenia gravis, and they also suppress general immune function. So, it has obvious side effects: weight gain, hypertension, diabetes, osteoporosis, psychosis, but also because it's a steroid, corticosteroid, we have to be very aware of infection because of the fact that it's suppressing their general immune function. So if it's something that they're going to need longer term than just that time that they need it for the moderate to severe myasthenia gravis exacerbation time, then they'll need to have education on being aware of reducing infection risk, practicing good hygiene, avoiding exposure to people with infections, those types of instructions. All right, another medication is azathioprine or Imuran. It's a steroid-sparing targeted immunosuppressant. So it's another immunosuppressing drug, but it's a targeted immunosuppressant medication that can be used. So it inhibits T cell and B cell proliferation through interaction with purine metabolism and nucleic acid synthesis. Another medication that's a targeted immunosuppressant is cyclosporin. So all of these that are targeted immunosuppressants will have the same side effects and things to watch out for as the other immunosuppressants like prednisone and corticosteroids. So these targeted ones are a little bit more specific because it inhibits that T cell and B cell proliferation. Cyclosporin inhibits T helper cell mediated synthesis of cytokines and other T helper cell mediated immune reactions. And it's just, if those corticosteroids like prednisone aren't working, then we'll go to the cyclosporin or azathioprine to see if it'll work for these patients. So it's a more specific immunosuppressant. Some of these patients, they say that the time to treatment response is approximately 7 months. So they may have to be on those for a long time. Okay, another one is mycophenolate mofetil or Cellcept, which suppresses both T cell and B cell proliferation. It is, let's see, usual dose is 1 gram twice a day. Some adverse effects are diarrhea, anemia, leukopenia, infection. So it's another immunosuppressant drug, and it blocks lymphocyte production. So you want to monitor for signs and symptoms of infection. It does cause bone marrow suppression, nephrotoxicity, and hepatotoxicity. So I want to be careful with those patients that could develop that. And another one is cyclophosphamide or cytoxin. It's a chemotherapeutic agent, which can also be used in the management of myasthenia gravis. So at high doses, the medication is used to ablate bone marrow or destroy bone marrow and allows the patient's endogenous stem cells to repopulate the immune system with new lymphocytes. So this approach allows the patient's immune system to do a good reboot. There's also IV immunoglobulin, which is IVIG infusions. It's a blood product. It's composed of purified and concentrated immunoglobulins or antibodies from the pooled plasma of healthy donors. And what it does is it binds to circulating antibodies and it promotes ACH availability and muscle function. So it can be used in acute interventions to decrease the severity of myasthenia gravis exacerbations or even as a chronic maintenance therapy, or even pre-thymectomy, so right before surgery. These infusions are super expensive and they also take a while. They run like 4 to 6 hours, depending on the dosage. You have to be really careful. You have to watch for reactions. It's just adverse reactions have been seen in about fewer than 10% of patients receiving. So it's kind of a higher risk medication when it comes to adverse effects. But it's kind of all the other ones you might see for blood transfusion. So circulatory overload, renal failure, nausea, vomiting, headaches, aseptic meningitis, thrombosis, stroke, seizures, skin rashes, alopecia is another adverse reaction of that. So just be mindful of what the facility you work for, what policy they have for IVIG. It's very institution specific regarding dosage and rates. And they may even decide to do a test dose to make sure that the patient doesn't have an adverse reaction, and then they'll do kind of a gradual increased rate as they tolerate it. And then they'll have specific policies in place on what to do if they do have adverse reactions, kind of like a transfusion reaction plan. It's the same thing for IVIG. One other thing that they can do for medical management is plasmapheresis. So it's, or also called TPE. So it's a therapeutic plasma exchange. And this has been used in acute myasthenic crisis, and it's used for treatment also prior to thymectomy. So the goal of it is to help with the removal of these receptor antibodies from circulation. So it just removes those receptor antibodies. So some side effects include hypotension resulting from fluid volume changes, and then hypocalcemia from citrate that's used during plasmapheresis, causing dizziness, paresthesia, and headache. So just want to monitor more for that hypotension and fatigue. Okay, so for assessments, main thing with myasthenia gravis is we really need to pay attention to respiratory status and monitor for respiratory deterioration and muscle weakness. So we really want to pay close attention to any sort of change with those. We will monitor for hypoxia, monitor their oxygen needs. We'll carefully assess their motor strength and then monitor for any progression or worsening of the muscle weakness symptoms. We talked about the vital capacity test. So that's the one that tells us really about their level of respiratory weakness. And with the myasthenia gravis patients, they develop weakness of the diaphragm and weakness of the intercostal muscles, all those muscles that we use to help breathe. So with that test, that patient takes a really deep inhale as much as they can, and then they exhale and taking as long as possible to let out the air forcibly from the lungs. And then, so a patient with normal respiratory function has a vital capacity value of 65 milliliters per kilogram. And when a patient falls below 15 milliliters per kilogram, which is generally 1 liter, then respiratory deterioration may progress. So that's kind of our warning sign with myasthenia gravis patients, is that if their vital capacity test number is at 1 liter or less, then we know that they're at risk for respiratory deterioration. So we'll definitely assess their breath sounds, observe their respiratory effort. That's a huge thing. It's not only listening to lung sounds, but let's watch them. Let's see how well they can take a deep breath. And then if they're going to get any medication, we'll observe and see if that medication will help them to breathe better, just as that pyridostigmine or other medications that might help myasthenia gravis patients help with that muscle weakness and help them to breathe easier, and see if it improves, see if it helps them breathe easier. So if it's less than that 1 liter mark, then we'll notify the provider, because that respiratory deterioration could lead to respiratory arrest. And then hopefully it wouldn't lead to intubation and mechanical ventilation and then going to ICU. So we'll probably do some assessments of cranial nerves. We'll look at the bulbar symptoms, which are first to appear in about 16% of patients. We'll monitor if they have difficulty swallowing. We'll look at their aspiration risk. We'll do some good neurological assessments of the patients. And then again, that cranial nerve table 35.6 is on page 766. And we'll look for some dysphagia. So they may have weakness of the oropharyngeal muscles because they're at risk for dysarthria and dysphagia. And, it's important for us to make sure that we watch out for aspiration, especially during meals. So if it is a patient that's in the hospital and is eating and has myasthenia gravis, we want to make sure that we have somebody at the bedside, making sure that the head of the bed is upright, that, they're swallowing, they're not coughing when they're, that they're chewing, and that they're not getting fatigued while they're eating and chewing. And then we'll want to monitor their nutritional intake and output and daily weights, just to make sure that they're getting the nutrition they need, and that the weight is more for maintaining their nutritional status, not for fluid overload or that. For that sense, it's more just to make sure that they're having good PO intake, and that is essential. And then for those patients who are having difficulty with dysarthria, same thing, then can be at risk for aspiration because of the weakness of the muscles. So most likely they'll be on a modified diet, probably puree, just to make it easier for them so they don't have to use their jaw muscles so much. And next, for nursing actions. So what are we going to do for these patients? So we will definitely administer medications as ordered, and then make sure to do them at the prescribed times. It's important for these patients because we want to make sure that we're giving them the medications prior to the activities that require them to function, such as if we want them to swallow for their meals, then we want to make sure that they give their pyridostigmine, before they eat. So it has to be given 30 to 60 minutes before meals to help minimize that difficulty with chewing and swallowing. So we want to make sure that we give them their meds at the prescribed times to help maintain optimal muscle strength for them. And then we'll elevate the head of the bed when they're eating and drinking, because of that weakness that they can have. And then if they do have difficulty speaking because of that muscle weakness, then we'll establish a good way to communicate with them, whether it's writing or a board that has with faces. We used to use one of those communication boards in the ICU, just like we would use for vented patients, that had a ton of pictures on it, and it would show if they wanted to, if they were needed to be suctioned or turned, or if they were painful. So they could just point to the picture and it told us what they needed or wanted. Plan meals, again, when medications are at peak levels. So small, frequent meals will help maintain their calorie intake. And that's, we monitor their weight because weight loss can indicate that they have poor nutritional intake. And then we'll almost always have to have speech therapy and speak language pathology consulted. And usually they're going to have soft foods, mechanical soft diet, pureed, thickened liquids is recommended. And then if they need it, they can have a feeding tube in. If swallowing is impaired temporarily until, say they have a myasthenic crisis for a couple weeks and they need a feeding tube for that duration until everything goes back to normal, then we'll do that as well. And then one thing too is to plan for rest periods. I think it's good not only to plan, the meals around the medication time, but if they are needing to do therapy, like physical therapy or occupational therapy, that you're also planning that throughout the day when it's best after the medications, and then encouraging rest periods throughout the day as well. Sitting while activities of daily living are completing and trying to find ways to use energy conservation for them, so that when they are needing to use their muscles and, use energy, it's for something that's extremely important. So they're conserving their energy for more important tasks. All right, teaching. So, of course, we're going to talk to them about what medications they're going to need, especially at home, the importance of timing, especially when it's involving food, eating, drinking, even brushing their teeth. Other activities that are going to be, need to be performed at certain peak times throughout the day and times that they'll get their medications. And then we want them to make sure that they have their medications with them all the time. They have spare doses with them. They should have a medical alert bracelet, especially if they're going to be on immunosuppressants, that they should avoid public places. Have them do the vaccines for flu and pneumonia, depending on their age, and then to do frequent rest periods and frequent breaks, and plan activities during peak energy periods. Let's see. And they do have the Myasthenia Gravis Foundation of America that has lots of resources for patients that we can direct them to as well. So let's do a couple review questions. So a patient is diagnosed with myasthenia gravis. What information does the nurse include in an explanation of this disease process? Your nerve endings are no longer functional, and that leads to muscle weakness. Your body has a disorder that destroys receptor sites at the neuromuscular junction, leading to decreased nerve conduction. Your body does not make enough of the neurotransmitter needed for movement, or your nerves have lost their protective covering and impulses are not as smooth. So you can either pause right now and wait to answer, or I'll keep talking and give you the answer. So the answer is 2. Your body has a disorder that destroys receptor sites at the neuromuscular junction, leading to decreased nerve conduction. So remember that circulating anti-ACH, those antibodies bind with the ACH, resulting in complement-mediating destruction of the receptor sites. So the antibodies destroy the receptor sites. Okay, a patient is being prepared for a tensilon test. What does the nurse ensure is available before the beginning of this test? oxygen, atropine sulfate, dexamethasone, or epinephrine. It's going to be atropine. So remember that with Tessalon, it's a rapid-acting acetylcholinesterase, or ACAG, inhibitor. This leads to increased levels of acetylcholine at the neuromuscular junction, leading to improved muscle strength in patients with myasthenia. So the ACH accumulates in the parasympathetic autonomic nervous system that causes that bradycardia. And then atropine essentially will help reverse those effects of the medication and will help bring the heart rate up. So we definitely need a little atropine at the bedside or when they're doing the test wherever they're at. Okay, a patient with myasthenia gravis is experiencing sweating and pallor after administering adrefonium or tensilon, which findings suggest the patient is experiencing a cholinergic crisis. Improved muscle strength, fasciculations, strong hand grasps, or equal shoulder shrugs. It's 2, fasciculations. So if tensilon is administered and the patient demonstrates fasciculations and muscle weakness, including respiratory muscles, it is a cholinergic crisis. A patient with myasthenia gravis has lost 6 kilos of weight over the last 2 months. What should the nurse suggest to improve this patient's nutritional status? Eat 3 large meals per day. Plan medication doses to occur before meals. Restrict drinking fluids before and during meals, or increase the amount of fat and carbohydrates in meals. 2, correct. Plan medication doses to occur before meals. So remember, we want to try and plan that when medications are at peak levels. So if they're taking pyridostigmine, it takes 30 minutes to 60 minutes before it starts to really be work to take effect. And then we want it to have that really be in effect when they start to eat. So we want to minimize the issues that they might have with chewing and swallowing. Okay, so let's start talking about Guillain-Barre syndrome. So with Guillain-Barre syndrome, about 2/3 of patients who develop this will have clinical manifestations of an infection 3 weeks prior to the onset. Many common viruses precipitate GBS. So it is a syndrome that really it affects the immune system. A lot of this is immune system driven, and it attacks the peripheral nervous system. So it's our body attacking the peripheral nerve system. So we talked about infections that about 3 weeks prior to onset of symptoms. So some of the infections can be respiratory or gastrointestinal, which tend to be the most common sources. And there's one cytomegalovirus or Epstein-Barre virus, and this Campylobacter jejuni is the most frequently identified cause of Guillain-Barre syndrome, GPS. But the others, such as cytomegalovirus, Epstein-Barre virus, mycoplasma pneumonia, and Haemophilus influenza, are also causes. So a very interesting connection there in that case, how it can develop that. There also is recent evidence that there's a link between the Zika virus and Guillain-Barre. So they're not quite sure what the link is between the Zika virus and GBS, but mortality rates range from, let's see, the pathogenesis of it. They're just saying it supports a complication of a link between the Zika virus and actually in adults. So that's just interesting. Okay, mortality rates range from 2% to 10% from autonomic dysfunction. And then complications of immobility, and that complications do increase with age. Patients are more likely to die if they're over 60 years of age, and they have a rapidly progressing variant of GBS, or they also require an extended course of mechanical ventilation. So, pathophysiology, it's mediated by an immune response with acute lower extremity weakness with areflexia or diminished reflexes developing over several days. So, we talked about an infection usually precedes the development of it. The patient's own immune system begins to destroy the myelin that surrounds the peripheral nerves. Destruction occurs between the nodes, which impairs the conduction that results in the that slows the impulses, or that conduction block. So it really is the destruction that happens between the nodes that are on the myelin and the peripheral nerves. So that conduction essentially slows and the impulses don't get through. There's a conduction block. There's an infiltration of lymphocytes into the peripheral nerve system too, and that attracts macrophages, and they also invade the myelin, and they get demyelination, and they can be seen. So these lymphocytes can be seen at these points of myelin breakdown if they were to take a microscopic exam of it. But the axons of the muscle usually stay intact. Or the axons of the nerve, excuse me. So in addition to affecting the myelin on these nerves, on the cranial motor nerves, sensory function is also impaired. So it affects quite a bit on the nerve. The patient's immune system produces antibodies too in response to fight that viral or bacterial illness. These antibodies are also produced that attack the myelin of the peripheral nerves. So they're thinking that somehow it's related between the infection that the body is trying to fight and the immune system creating these antibodies that also attack the myelin on the peripheral nerves, and then essentially breaking down that myelin and the sensory function. So nerve damage that you will see with these patients, they'll have numbness and tingling, they'll have muscle weakness, they'll have paralysis, and potentially even respiratory compromise. There are 3 stages of GBS. The first stage is known as the acute stage, which starts with the onset of clinical manifestations. So that's where they have that first part of the peripheral nerve demyelination. So that's the first part of the destruction of the nerve sheath, destruction of that myelin sheath, and edema and inflammation. So that first part of destruction of the myelin. That phase lasts approximately 4 weeks. When demyelination ceases, the patient enters the plateau stage, which lasts from a few days to weeks. And then the third stage, which is the remyelination or regeneration stage. And then that's just a gradual improvement in the patient's signs and symptoms. Clinical manifestations, we talked a little bit about that. So they develop it's symmetrical. So it's the same on both sides. So it's ascending motor weakness, paralysis that usually starts in the feet and extends to the trunk and arms. So an easy way to remember the pattern of weakness in GBS is it starts in the toes and up it goes. So starts in the toes and up it goes. So there may be sensory involvement. It just depends. Patients may complain of paresthesias and pain that involves the shoulders, back, buttocks, and upper legs. After the first few days of weakness, neurological assessment demonstrates diminished or absent deep tendon reflexes, which is areflexia. So areflexia is recognized as a key finding in GBS. For this illustration, you can see some of the risk factors of developing possibly autoimmune. Sometimes it's associated with immunizations. Think about the immune response that we get with immunizations, and then usually from an infection 3 weeks prior. And then where it starts begins in the lower extremities and moves up, and then what it typically can cause problems with. So it's symmetrical paralysis, causes problems with respiration, talking, swallowing, bowel, and bladder function. Diagnosis and treatment. Of course, we're going to ask about the history. You know, we want to know what if they were, if they had an infection over the last few weeks. And then we'll also ask them about whether or not they've had progressive weakness of 2 or more limbs, if they've had neuropathy. We'll look at reflexes and if they have reflexes or not. And then, definitely find out if they've had that recent viral or bacterial infection. They'll do a lumbar puncture and they'll look at the cerebral spinal fluid. And what they want to look for is if they have an elevated protein and normal cell count, because that'll tell us that they have GBS. They can also do an electromyography, and that would reveal slowed nerve conduction velocity soon after the patient develops paralysis. So treatment for GBS, it's mostly supportive care, really reducing the severity, potential complications, suffering, and recovery time. So it's an autoimmune disorder. Really, steroids have not been found to help speed up recovery. Unlike myasthenia gravis, we might use steroids. We don't use steroids with GBS. It's debatable. I think it used to be pretty common to use corticosteroids with GBS, but current research is leaning toward patients with not receiving corticosteroid therapy. They also would use IVIG and plasmapheresis for these patients because it can help shorten the length of the shorten the recovery phase by 50%. And this therapy is recommended for patients who need help to walk within 2 to 4 weeks of clinical presentation of GBS. So it does help with recovery. And then, this treatment, again, it helps by blocking macrophage receptors, and it inhibits that antibody production and inhibits complete binding and neutralization of the pathological antibodies. So definitely will help. Adverse effects sometimes include flu-like symptoms. We talked about some of the rare adverse reactions, which are aseptic meningitis, acute renal failure, can be fluid overload in patients with heart failure. Just remember to follow your facility policy on IVIG and plasmapheresis, and review what was said in the myasthenia gravis section of the lecture on that medication. Some complications of GBS. So respiratory status is monitored in terms of breath sounds. They'll look at forced vital capacity as well. So with ventilation, it can be compromised because there's loss of motor innervation to the skeletal muscles of respiration. So they can be at risk for respiratory compromise. We do need to monitor the airway. They may require intubation mechanical ventilation. So we do monitor for that. We'll monitor their airway and respirations and oxygenation. So during the course of GBS too, the patient's also at risk for developing complications of immobility. So we're going to watch for DVTs and PEs, and we're going to do lots of frequent turning. So we'll do our DVT prophylaxis. We might do anti-embolism stockings or SEDs. They're also at risk for developing pressure injuries, so we'll put them on a turning schedule. And then they also tend to perspire because of their autonomic manifestations. So the patient's clothing and linens might need to be changed more frequently to prevent areas of moisture and promote good skin integrity. So what are we going to do for these patients? We're going to do grade assessments, definitely respiratory assessments. So we're going to look at respiratory muscle weakness, assess lung sounds, assess respiratory muscle rise and fall, and respiratory rate. And we will also assess pain and sensation. So autonomic manifestations as well as sweating and tachycardia and vital signs and whatnot. We will look at skeletal muscle weakness. It's often ascending, so from toes and up. And main thing again with these patients is that we do good monitoring and look for trends and see if there's any changes so that we can alert the provider. A lot of it is supportive care for these patients. And depending on the severity, we'll of course watch for aspiration, skin breakdown, DVT prophylaxis. We'll want them to participate in as much care as possible that they're physically able to, depending on their symptoms. They'll be weak, but they are still alert and cognitively intact, so they are still hopefully mindfully stable for you. And then it can be very frustrating for these patients, especially if they're younger, to be locked in a body like that and not be able to move. Let's see. We'll do good motor and sensory assessment, especially with the demyelination of the peripheral nerves. So we will monitor for sensation and numbness to see if any of that is improved for the patient, and then a good pain assessment. All right, nursing interventions, we're going to turn frequently, do range of motion. They're at risk for contractures, skin breakdown, so monitor for that. They'll probably be on Lovenox or subQ heparin. They'll have SEDs. And then, let's see. We'll go into teaching. So for teaching, we'll do respiratory monitoring, of course. So especially in that acute phase, just to see how much of their respiratory muscles are affected. And, just depending on how long the disease course lasts, it could be several weeks to months, depending on those stages. The goal, of course, is for them to return to their baseline functioning. That it's a neurological disorder and it's going to take time. So just try to teach the family and patient about each stage of the illness, to watch out for respiratory deterioration. If they start to have difficulty breathing, that, they need to let you know. Let's see, let's do some review questions. And then referral to resources. They also have a website as well, just like the Myasthenia Gravis one. So review questions. So a patient with Guillain-Barre syndrome asks how the illness develops. What should the nurse respond about the pathophysiology of the disorder? It's an infection that destroys the nerve endings. An infection enters the spinal cord and erodes the nerves at the roots. The nerves are killed by infiltration of your body's white blood cells used to fight an infection. The covering of nerves that help conduct impulses is damaged. Four is correct. The covering of nerves that help conduct impulses is damaged. So remember, the patient's own immune system is destroying the myelin on the nerves surrounding those peripheral nerves. Destruction specifically occurs between the nodes of Ranvier that results in slowing of the impulses and conduction is blocked. There's infiltration of lymphocytes into the peripheral nerve system that attracts macrophages, and the macrophages penetrate the Schwann cells and invade the myelin, resulting in demyelination. Okay, so the nurse is planning care for a patient with Guillain-Barre syndrome. Which intervention will help with the neuropathic pain? Administer gabapentin, turn and reposition every 2 hours, apply SEDs, perform passive range of motion exercises several times a day. The first one, gabapentin. So gabapentin may be used to relieve neuropathic pain. Trying to think if maybe, so we talked a little bit about medications. Gabapentin can be used to relieve some of the neuropathic pain. We talked about steroids a little bit and IVIG, but again, mostly it's supportive care. So gabapentin can certainly be used for any of the neuropathic pain, nerve pain that they're going to have. Okay, a patient being evaluated for Guillain-Barre syndrome presents with bilateral symmetrical muscle weakness and sensory changes of both feet and legs. The nurse correlates which key finding to this disease process: areflexia, hyperreflexia, hypothermia, or hyperanalgesia. It is areflexia. So after the few days of weakness, neurological assessment demonstrates diminished or absent deep tendon reflexes, which is areflexia. So that is a definite key finding. All right, so let's move on to trigeminal neuralgia. This is our last subject we're going to talk about. So there's about 15,000 people in the US that are diagnosed with it each year. It's more common in women than men, and it rarely affects people under the age of 50. So some risk factors for it are hypertension and people who have multiple sclerosis or MS. So the reason for the risk factors of those patients who have MS is that there may be an area of demyelination along the nerve that contributes to the increased incidence. So that's a potential. But for most cases, they really don't know. It's kind of an unknown for some of these. Trigeminal neuralgia as well. So pathophysiology, it's usually a sudden, unilateral, severe, brief stabbing, recurrent pain in the distribution of one or more branches of the trigeminal nerve, which is cranial nerve 5. So in classic trigeminal neuralgia, the etiology is unknown. Could be due to vascular compression. In some cases, it's associated with a tumor or even a structural abnormality of the skull base or multiple sclerosis or MS. The second type of pain is atypical pain, which is constant burning. So it's a sensation that they get that covers a more diffuse region of the face. I'll show you an illustration up here that kind of is easier to see what that means with it being a diffuse region of the face. Clinical manifestation. So they often report that their pain really began spontaneously, whereas others relate that their onset of clinical manifestations kind of followed dental surgery or facial trauma, motor vehicle accident. It's usually very sudden. It'll be a sharp throbbing, shock-like pain. Triggers may include an area of the skin or an activity such as brushing the teeth, drinking a beverage that's really hot or really cold, smiling even, or talking. Sometimes even the breeze from opening the door can trigger the pain. And then like we talked about brushing the teeth, but even bathing or shaving can be another one that can trigger the pain. And then patients can have anywhere from 1 attack per day or as many as 10 to 15 attacks an hour. So here's trigeminal neuralgia affecting the three areas of the cranial nerve 5 there. So you've got the ophthalmic, maxillary, and mandibular zones. This next image can help illustrate those areas a little deeper. So with cranial nerve 5, you see the trigeminal nerve there. And then that nerve has 3 branches that go out there. The function of cranial nerve 5 is temperature, touch, pain sensations from the upper and lower face, and then chewing. So you can see how all those triggers would affect that trigeminal nerve. All right, so medical management, diagnosis. So it's primarily based on the clinical presentation and ruling out other pathophysiological processes. So really it's, a direct injury of the cranial nerve or tumors or TMJ or other types of jaw injuries. They'll do a comprehensive neurological assessment. They'll look at trigeminal reflex testing. They can do an MRI to see if anything else is going on in there. They might do some blood work too. They can do an ESR or erythrocyte sedimentation rate, which can tell us if anything inflammatory is going on. There's also this anti-nuclear antibody titer, or ANA, which would show up positive for these patients. So that's one indication. And then they might also do a CBC to look for any other hematological abnormalities. Just depends on the patient. Medications used to treat these patients, it's usually anti-epileptic drugs, such as carbamazepine or oxcarbazepine or gabapentin for nerve pain. So carbamazepine or Tegretol is an anticonvulsant. It also is a mood stabilizer, can be used for a couple different things, but it's the first line of medication therapy used in the treatment of trigeminal neuralgia. It works by reducing the excitability of neurons by inhibiting the neuronal sodium channels. So that's it. It does help. It's very effective for these patients. They can also do baclofen. So baclofen works as an anti-spasticity drug, centrally acting on the skeletal muscle. It's a muscle relaxant. So this also can help to decrease pain with the patients that have trigeminal neuralgia. But, side effects are that it can cause dizziness and drowsiness, so they may not be able to take it throughout the day. There's also surgical management that they can do. So medications can be pretty helpful in abating the pain and some of the symptoms, but sometimes they might need to have surgery if medications aren't working well enough for them. So there's a few different procedures. There's a percutaneous rhizotomy. It's rhizotomy, rhizotomy. So in this procedure, they have a needle that is inserted through the cheek into the foramen ovale, and then the nerve fibers are damaged or destroyed by radiofrequency. So they essentially damage those nerve fibers in the trigeminal neuralgia by radiofrequency. And then they do a glycerol injection or a balloon compression. The only problem with that is that they will have permanent facial numbness in the region supplied by the branch. So you don't want that one. There's also a stereotactic radiosurgery. In this procedure, they give a high concentrated single dose of ionizing radiation to the precise target at the trigeminal nerve root. And this dose of radiation causes a lesion to form, which interrupts that pain transmission to the brain. The most effective surgical treatment for this disorder is microvascular decompression, and it's the most invasive procedure, though. They do a craniotomy, and it's performed to the suboccipital region. The neurosurgeon performs neurovascular decompression by placing a shredded fluorocarbon resin pad between the vessels and the nerve. And the most common vessel to cause compression is the superior cerebellar artery. Facial pain is relieved within 24 to 48 hours, and the patient doesn't have any residual facial numbness. So that might be why it's the most effective surgical treatment. And that is it for medical management. So nursing assessments for these patients. Really, we're going to administer medications as ordered, try to help them relieve any of their symptoms. We'll do their anti-epileptic medications if they have been on them, any analgesic medications that they're on as well. If they're trying any non-pharmacological strategies, we'll help them with those as well. Acupuncture, I guess, has been found to be pretty effective, just as effective as carbamazepine. So that's another option for patients to try is acupuncture. And, we want them to be able to, really identify and avoid any exacerbating factors. So have them identify what are some of their triggers, what are things that they definitely know cause that pain, and what can they do to avoid it. There might be some things that they can't avoid, like brushing their teeth, but if it's cold weather, drafts, is there anything they can do to avoid that situation? And because the pain can be so severe and interfere with activities of daily living, it's important that they try to minimize factors that can cause or exacerbate the pain. But hopefully medications can help with that too. Let's see. It's really about proper pain management and pain control. And they do have a society called the Facial Pain Association. So let's do some review questions. Let's see, did I miss actions and teaching? Okay. Just the slide that I missed for you guys was to go for actions and teaching. So nursing interventions, actions, administer medications as ordered, and then teaching, what I was just talking about for the patients. Review questions. So the nurse correlates which data from a patient's history as a risk factor for trigeminal neuralgia. Has a body mass index of 34, takes birth control pills, a history of hypertension, or works as a computer operator. And has history of hypertension. Hypertension is a risk factor for the development of trigeminal neuralgia. Okay, the nurse is reviewing orders for a patient admitted for evaluation of changes in neurological status. Which prescribed medication does the nurse correlate as a treatment for trigeminal neuralgia? Cogentin, compazine, carbamazepine, or hydrochlorothiazide? Let's see. It is carbamazepine. So it's the first-line drug. It's the anti-epileptic. Works by reducing the excitability of neurons by inhibiting the neuronal sodium channels. The other question that was on history of hypertension. So I might look into that a little bit because when I was preparing this lecture and in the book, I do not remember reading anything about hypertension. And I thought I had included everything in the lecture from the book on what some of the risk factors were. Because as far as I know, it was MS. Oh, it is. Yeah, neuralgia or hypertension and MS. Okay, sorry. I did include it. Okay, so let's move on to the next question. The nurse is reviewing orders for a patient. Oh, my goodness. Right, I think that's it for questions since we already talked about carbamazepine. We talked about risk factors, and we talked about all of our, let's see, talked about all of our review questions and did those answers. And I think that is it for today's lecture. So we went over Myasthenia gravis, Guillain-Barre, trigeminal neuralgia. Now, chapter 38, there's case studies that you can do. They have wrap-up questions, and there's case study questions too that are really good. And you can look for those online on Effie Davis. And then there's a practice quiz linked on Canvas, I believe. There's also Davis Edge questions if they're available. And then also just review the notes, and I will make sure that I post all of the notes that are from this lecture for you online after Tuesday. I might wait a day or so to make sure that all of you have listened to me first, rather than just looking at my notes. And if there are any questions at all, just please let me know and email me. Thank you for a great lecture.